presentation in Michigan Medicine's Healthy Aging series. The series is entitled The Art and Science of Successful Aging. My name is Craig Ramsey. I will be the moderator for today's lecture. I will introduce today's speaker shortly and then return after her presentation to assist with the question and answer session. You can submit your questions for the speaker through the Q&A feature of Zoom, which is at the edge of your screen. Before going any further, though, I want to thank the Planning Committee and the programs that helped to make this series possible. They include the University of Michigan Department of Geriatrics, the Turner Senior Wellness Program, the Osher Lifelong Learning Institute, Silver Club Memory Programs, the Turner African American Services Council, the Institute of Healthcare Policy and Innovation, and the National Poll on Healthy Aging. You should also note that this presentation will be recorded and sent out to all registrants at a later date. If you have any technical difficulties with Zoom during the event, I would recommend first that you click the Leave button on the Zoom screen and then re-enter using the Zoom link that you used to enter to begin with in the session. That will usually resolve what issue you might have, such as a frozen screen or something like that. But if that doesn't do the job, you should then put a message in the chat, click on the chat icon, and put a message in there indicating the kind of difficulty you're having, and there will be assistance for you through that chat message that you sent. So hopefully neither of those things are a problem for you one way or another. It is now my pleasure to introduce today's speaker, Professor Sheria Robinson-Lane. She's an assistant professor at the University of Michigan School of Nursing in the Department of Systems, Populations, and Leadership. Dr. Robinson-Lane's work aims to reduce health disparities and improve health equity for diverse older adults and family givers, managing pain and chronic illnesses such as Alzheimer's disease. Her research addresses the ways in which older adults adapt to changes in health status, and particularly how various coping strategies affect health outcomes. As an expert in long-term care and hospice palliative care practice, Dr. Robinson-Lane has also done significant work over the past year providing community education on COVID-19, COVID vaccines, and managing care of the elderly adult during the pandemic. Dr. Robinson-Lane completed her Ph.D. in nursing at Wayne State University, along with a graduate certificate in gerontology. She also completed a postdoctoral fellowship in advanced rehabilitation research training at the University of Michigan Medical School in the Department of Physical Medicine and Rehabilitation. Dr. Robinson-Lane's presentation is entitled Health Disparities and the Older Adult, Why Race, Class, and Region Matter. And I should note that this is the first of 4 lectures in the month of February through this series on various aspects of health disparities. So you can be looking for those in upcoming weeks. Well, now, Professor Robinson-Lane, the virtual podium is all yours for your presentation. Welcome.
Thank you, and thank you so much for the invitation. I'm absolutely delighted to be here and to kick off the series for this month. And I hope that everyone finds some content here that they find helpful, that changes perhaps some of their perspectives. And I'm also looking forward to the discussion at the end. So my funding is primarily through the National Institute of Health, where I'm currently funded on a K01 training grant, and am thankful for the support that this has provided to continue much of my work and being able to also do presentations such as this one. I think because this conversation and much of the month is going to discuss health disparities, I think we have to be really clear about what health disparities are. And so we know that disparities are differences. But when we talk about health disparities, we really are talking about preventable differences in health. And more specifically, these are preventable differences in disease burden, injury, violence, and ultimately opportunities to achieve optimal health. And so this can influence the risks that you might have for getting a particular disease, how likely it is that you're going to get diagnosed for something like cancer, or when in the disease process you might get diagnosed, like an Alzheimer's disease, where we see much later diagnoses based upon race and ethnicity. It can make a difference in how your disease progresses, the treatment options that are available to you, and then the treatment responses. Who takes care of you when you get sick? What sort of access to care you receive once you get sick, and ultimately, like, what is your quality of life can be influenced by these preventable differences. And things like your socioeconomic status, the education level, access and quality that you have access to, as well as where you live, all play a factor in the differences, these preventable differences that we can see in healthcare outcomes for individuals. And certainly lifetime and lifestyle differences play a role. But one of the things I'm going to challenge you today is to perhaps think about lifestyle and lifetime within the context of, are those choices that people make, or are those the choices that are available to them that then influences their health? And one of the large underlying currents that I think that we've been talking much more openly about over perhaps the last 2 years in particular is the role of racism within health disparities and how that has influenced care and care outcomes for individuals. One of the things specifically about racism that I don't know is at the surface is that racism really operates at 4 different levels. And I want to take it back a notch and say that when we're talking about racism, you can switch out any of the isms for racism. So anytime we're talking about an individual that is discriminated against, or there's a practice of viewing a group negatively based upon their social position or status or race or ethnicity, any of those isms. So whether it is heterosexism and only favoring people who fall within that group, or whether it is isms against individuals of a particular gender, or of a particular religion. All of that also can operate at these various levels, which generally fall into the micro and macro level. You could argue that some is in the meso, in the intermediary level. So let's just take a minute and consider what that looks like. So at the individual level of racism, what this is the bias, which we all have various biases. They don't necessarily translate into a particular ism, but they're the personally held biases and beliefs that specifically are around race and ethnicity. When we're talking about racism, that support a negative and often stereotypical view. At the interpersonal level, that's when those negative, and so at the individual level, this can affect your decision making. So it can make a decision, you know, how, whether or not you choose to go to a particular neighborhood because of the biases that you may feel, whether or not you choose to engage with someone or not, what's how comfortable you are in different settings. And so this has nothing to do with whether or not, like, when you're actually engaging with someone, this is before it even gets to that space, but the own beliefs and ideas that you have that can influence that. At the interpersonal level, this is when those personally held biases and beliefs begin to influence your interaction with other individuals. Then at the institutional level, which is much more important, is when these individual ideas become embedded in the ways in which we conduct business as organizations. So you begin to see it reflected in policies, procedures, practices, the power structure. So who is in charge and why is that person or these groups of individuals, why are they in charge, and then what opportunities are available or unavailable based upon the determined hierarchy within an organization. And then at the highest level is structural, in which we see that there's really societal conditions and laws, and again, the same power distribution and allocation of resources that reinforce these structures that support discrimination and bias. And so if we take a look at this and give some examples here at the individual level, this is really, again, what we're thinking about ourselves and then how this influences our behavior. So whether or not you choose, for example, to make eye contact, or when you're going through the grocery store line, how comfortable you feel in talking with the cashier and engaging them in conversation. Sure, some of this may have to do with cultural differences, the ways in which we were raised to sort of survive in the world. But how much of this is based upon biases and the ways in which we might feel about other individuals that influence how we interact with them. At the interpersonal level, racism begins to affect relationships. It affects further how we communicate, our expectations, and our presumptions that we have. And then when we talk about, again, at this organizational level, this is where it sort of reinforces ideas that we have that are often based on stereotypes. And so here you have an ad that doesn't seem like it's necessarily a big deal. It says some Notting Hill folks were born to dance, others to sell flats. And in the ad, there's a picture of a Black male dancer who's definitely a dancer. He's an artist and he's a director of a school. So both of these things are true. The gentleman on the other side is a white male with a suit on, and he is a realtor. So both of these things are true. The problem with this ad, and the reason why this ad, which was an ad that came out of London, I believe, or it's a British ad for a British real estate firm. The reason that was problematic is because it reinforced the stereotype that Black people dance and that white folks are good at business. And so what might this ad, how might it have been perceived differently if, for example, there was a Black dancer, but then also a Black realtor there? Or perhaps instead of having a Black male dancer, there was a white male dancer, and a white male dancer that was in a ballet artist. This ad might then also have been perceived very differently. But the reason that it was problematic was because it reinforced some widely held stereotypes about individuals. And so by reinforcing those ideas, it sort of continues this cycle, if you will, of thinking about how individuals fit into particular spaces and then how the decisions are made. And so one of the things that we really have to think about, if bias can be embedded into our decision making, is how does that then influence how we look at things from a scientific perspective? Why do we look at things in particular ways? And another way of saying that is when we are MC Hammer and talking about science and the relationship between science and philosophy, asked that if science is a commitment to truth, shall we cite all of the historical non-truths perpetuated by scientists? Of course not. It's not science versus philosophy, it's science plus philosophy. Elevate your thinking and consciousness, and when you measure, include the measurer. And so what that really means is we really have to be thoughtful about the role of bias that influences how we evaluate science, how we think about science, and even how we think about data. And the reason that all of this relates back to this conversation about how racism influences health is that when race has played a very, and particularly racism, has played an incredibly large role in how the current health of individuals are currently positioned across the US. And what's interesting about all of this is that race is really a social construct. It's not biologically necessarily based. One of the great findings of the Human Genome Project and several other studies, but predominantly of the Human Genome Project, where we've been spending a ton of time examining the genetic relationship between disease and health and physical health, the ways in which people physically present, is that what they found is there really isn't a lot of genetic variation between racial groups. Individuals of different racial groups are genetically often very the same. What does occur, however, is that there's more genetic variation of individuals of the same or within racial groups than there are outside of them. Social factors actually explain more than biological factors. The other thing to keep in mind is that race is often time and context specific. It's one of the reasons that, for example, Jews are considered a race in some instances because under Hitler defined them as a race and decided that they were a race that fell lower within the hierarchy, and then had racist laws and policies that then supported that viewpoint. But that's not necessarily the same in different time periods in that same view. And so it's very historically and geographically, it can change about race. So it's not necessarily just because race here in the US is limited to particular groups. It can look different in other countries and settings around what racism looks like and who and where people fall within the racial hierarchy. One of the challenges is that even though race is a social construct, throughout history, there's been a consistent effort to sort of try and prove the point that not only is there a hierarchy, but individuals within this hierarchy are definitely on top and are superior, and there's other individuals that are inferior. And so, for example, one of the large proponents of this work and these false beliefs around racial hierarchy was a physician, Thomas Hamilton, that was well known for doing lots of work, experimentation on slaves to support these false beliefs that he had. He was in a position of power in that he was the trustee of the Medical Academy of Georgia. He was a plantation owner, so he was very wealthy, and then he was a physician. So he was well known and well regarded within the community. His beliefs were that Black skin is thicker than white skin, that Black persons have a higher pain tolerance, and that the blood of Black persons actually coagulates slower. And so he did a number of experiments on slaves without anesthesia to test these various hypotheses, and published on this work. The reason that we're aware of the work that he did, besides his own work that he tried to publish, was because one of these individuals that he experimented upon actually wrote a book and later became an abolitionist and wrote about his experiences of being experimented upon by this physician. And so in the book, for those who are interested, it's called Slave Life in Georgia, which was written by John Brown. And it gives some very harrowing accounts of this experience of this life that took place here in the US. The reason that I'm bringing this up is because these views that were started by this physician based upon these experiments that began, that were rooted in bias, have maintained. What we see today is that we still continue to see these same views in medical education and in student knowledge that contribute to health disparities or preventable differences in health outcomes. This was a study from 2016 in which they still were finding that there's racial bias in pain assessment and treatment, and much of it was related to false beliefs about biological differences between Black folks and white folks. And again, these ideas can be directly linked to a lot of this stuff that Hamilton was working on years ago. And so again, when we think about health disparities and differences, and we began to look at data, it's really important that we start to consider what is the bigger picture here. And we began to ask questions about the context behind what are the contextual factors, if you will, that contribute to some of the differences that we're seeing. So for example, and recent, this is recent COVID related data from a study in which we looked at patients that had been hospitalized in Michigan hospitals and that were then discharged, and we evaluated them within those 60 days to identify differences in care outcomes in the 60 days after hospitalization. And so these are the racial and ethnic breakdowns of the group. The unknown category were simply individuals within the medical record where the race or ethnic background was not captured, or it didn't fall within one of these categories. They fell into the unknown category. And so what you can see here is that when we look at the age of the participants, there is about an 8-year age difference between Black and white participants. There also is a higher body mass index amongst Black participants. And so the body mass index is a ratio or a number that we find by looking at the ratio of your body weight to your height. And it's one of the measures that we use to determine obesity. And so the really all of the groups that are from minoritized backgrounds, with the exception of Asian, tend to have a higher body mass index. And then unsurprisingly, there's a higher amount of diabetes within these groups. Interestingly, even though the Asian groups has a lower body mass index, there's still a much higher rate of diabetes. And so, and you can see across the board, there's various differences in health outcomes between these groups. Hypertension is higher, kidney disease is higher. The former smoker is a bit lower, and that's because what's not included here is current smoking status, and the current smoking is a bit higher within the minoritized groups. And so one way of looking at this data without thinking about things from a health disparities lens is to say, Black folks are having all of these health conditions because they are more overweight. And so if they would eat better and control their lifestyle, they wouldn't have these sorts of problems, is one way of looking at it. And that's one of the ways that we frequently see happens. And then the scientific approach to addressing that is, because Black folks are more overweight and having all of these other problems, the solution then is to teach them to eat better. And then we have interventions that are focused on healthy lifestyle and that sort of thing. The challenge is that this doesn't consider these contextual factors. Remember all of the stuff that we talked about before that can contribute to these differences? All of those factors are not considered. So for example, there's two studies that I've just randomly pulled here related to food. And so one here was, it's an older study from, both of them are actually a little bit of older studies from 2007 and 2009, one in which it says that the association between access to food stores and adolescent body mass index. In this particular study, they found that there was an increased availability of grocery stores was actually associated with a lower body mass index in youth. So what that means is that the more grocery stores that you had where you live at meant that you were more likely or less likely to be obese or to have an issue with weight if there were more grocery stores in your area. And so anybody that knows anything about urban planning and the differences between living in a very urban area and a very suburban area, and let's even just be real specific and talk about Detroit, there are food deserts where it's very difficult to get access to a grocery store. And the second finding there, that higher availability of convenience stores is associated with higher obesity. And so is the problem access and reasonable access to fresh fruits and vegetables, or is it just simply lifestyle? The second study there, where it talks about food prices, access to food outlets, and child weight. This one of the major findings from that particular study was that as the cost of food, particularly fruit and vegetables, increased, and with these fruits and vegetables, they looked at some of the basic things that kids would often be eating, things like corn and potatoes, lettuce. So things that were, would be cross-cultural that you would see. And they looked at the frozen food prices as well as the fresh food prices, if I'm not mistaken. And what they found was that as the cost of fruits and vegetables increased, then the body mass index also increased. So people were consuming less the more that those fresh fruits and vegetables cost. The other thing, as it relates to food in general, is that there's often a saying that it costs less to eat healthy, which I always think is interesting, because as someone who does cook most nights and that cooks and prepares a lot of fresh ingredients, it's not necessarily the case that when you consider both time and cost, that it's necessarily cost neutral or that it costs less. It's actually more convenient and costs less to eat less healthy, to get, like, for example, a box of hamburger helper and a pound of ground beef versus, which may be higher in sodium, filled with carbs, has a lot of fat, versus cooking a more healthier version of that meal with a more lean meat. Even lean meat is more expensive. So the point here, again, is that a lot of these contextual factors over the lifespan contribute to negative health outcomes. And it's not just about what is available, but also it's where you live. If we take a look, for example, at this is the Detroit area. One of the things that some folks may be familiar with is this idea of redlining, which was a practice of denying or limiting financial services to certain to individuals, and particularly to certain neighborhoods, largely based on race and ethnicity. And so certainly there were some other factors that were in the redlining practice, such as what sorts of how close housing was to industrial areas, the status of the houses. But if you go back and actually, and much of this stuff is now, because they're in the process of archiving it, a lot of it is available online, where you can find these old red line maps as well as the narratives that go along with them. I didn't include the narrative descriptions because many of them are incredibly highly offensive. I mean, they're very descriptive in saying that, for example, a green area is considered a homogeneous area with minimal risk. So they were rated as A through D usually, and color coded as well. And so the A area was a green homogeneous area, all the way down to the red areas, which were hazardous, and often because they were Black and low income. And interestingly, when you look at the descriptors, it says first thing, like in some of the descriptors, that the area has a high proportion of Black, and I think in these reports, they refer to them as Negroes, Jews, and immigrants in the area. And so therefore it would be considered hazardous. And that's how many of these were described. Oftentimes the yellow areas were areas in which it might be a mostly white population, but it was listed as declining because it was bordering a lower income and Black population. And so the reason that I'm bringing this project up is that this is from 1939, and these sort of red line districts influenced how loans were given out by the banks locally, as well as the federal loans that were available to support housing. And so when you compare then or look at the Detroit Cumulative Risk Index, which this was developed by Amy Schultz and colleagues, that was based upon the Cumulative Risk Index that was developed by Rachel Morella Frosch and colleagues. This evaluates the location of like hazardous facilities, exposure risks, and health of the community and other vulnerabilities. And you can see that it looks really similar to this red line map. Looks very similar, right? So what started as a social policy then influenced the health of the area. And then if you bring it forward to currently, there are the Associated Press has a interactive life expectancy map. For those who are interested, you can go and take a look at that and actually put your zip code in and see what the life expectancy is for your zip code. On this map, again, it looks very similar, that the life expectancy down in this same area, and this is still a map of Detroit, is down in the 70, 73, 70, some of it down in the early 70s versus further out, the further you get away from the city, that the life expectancy goes up into the 80s. And so these differences are affecting health outcomes. So some of the things that we have to think about, again, is when we're looking at data and trying to understand these differences that we see in health outcomes, is ask the question, is it race or is it really racism? What are the contextual factors or other factors that are contributing to the health of individuals? And then what are the biases that might be present? One of the other things I think that's important to consider is this idea of intersectionality, or the how individuals can hold multiple marginalized identities. And this was a concept that was introduced by law professor Kimberly Crenshaw, who talked about in law what was happening is that individuals were not allowed to hold multiple identities when attempting to be treated fairly or to bring forth cases. And so specifically legally, there were some cases, for example, of IBM firing several people throughout the company. And basically, and when this happened, all of the Black folks in the company were fired, and particularly the Black women that were there were sort of at the lowest of the totem pole. And one of the things that happened is when this group of Black women went to sue, their case was essentially thrown out because it was determined that a group of women were suing, and so they would have to join the group of women, but they didn't recognize that being Black and a woman was like its own group. And so that's where sort of these, and then she has multiple examples of case law in which individuals were not recognized as belonging to multiple groups. And so what happens when we think about this from an organizational standpoint is that these folks that fall in the middle here are going to be the most marginalized. And so when we're thinking about creating inclusive communities, what you have to think about is who's going to be the most marginalized amongst the group, and is this a safe space for those individuals? And the reason that this relates to the older adults is that ageism is one of those isms that we don't talk about frequently that affects older adults, and that falls within this group where you can have individuals that simply might be older adults and not fall or feel as though they fall into one of these other groups, but then you have a whole lot of people who do. And so one of the things I think I always ask folks is like, think for yourselves for a minute, like, what do you consider to be old? You know, if you really think for a minute and you come up with an age and say, okay, that's old. Most people think of an age that is 20, 10 to 20 years older than wherever they are right now. Nobody usually considers themselves old until you get around, what I've found is around in the 80s, at some point, people start to consider themselves to be old. And then they may add to that and say, well, I'm old, but I don't feel old. But that still doesn't often happen until somewhere in the 80s. It's always some age older than where you currently are. And even when we think about our advertisements on television, all of the ads for beauty and for youth, this there certainly is a wide societal perception of what it means to be an older adult, and this influences both policy and practice. And one of the ways we saw this up close and personal was during the COVID-19 pandemic. The first outbreak that occurred was in a long-term care community where there were 50 residents and staff that ended up with flu-like symptoms in Washington state. And the way that the pandemic was framed at these really early stages was that this was a concern that affected predominantly elderly people and people with health problems and other problems. And so as a result of that, we saw a very different sort of approach to the pandemic than maybe would it have been the same approach if the first persons or individuals that had gotten sick were children. Do you think that we would have maybe had the same approach to the pandemic if there were young kids that were getting sick initially? And even most recently, we found the CDC director found themselves in some hot water in discussing the Omicron variant and talking about that it was mostly affecting individuals with disability. And so we see that there's often a sort of hierarchy that continues to take place in society where our policies and practices are not inclusive, and they promote health disparities. And so with COVID currently, as a result of many of these approaches in our current policies, we're at 75 million cases. And I'll tell you, I was just looking at this data because I presented at an international conference just last month. It's gone up by at least 10 million cases just in the last month. And we're at 888,000 deaths. I mean, we're going to end up hitting 1 million deaths related to COVID. And when you look at where the COVID cases are coming from, much of the cases are amongst younger adults, right? This 18 to 29 group. And I mean, there's cases throughout, but a lot of this age group was responsible for many of the cases, and that has been sort of coming together as time goes. But when you then look at the number where the deaths are, almost all of the deaths are people that are over 50. And so when we talk about trying to figure out ways in which to keep folks engaged and to think about the role of region and racism, health disparities, and all of these things play a role into the health into all of our health. It affects our policies. And the reality is as we age, one of the things that happens as we age is that we begin to have to think about aging with disability. The reality is that as we grow older, particularly with health conditions, those health conditions lead to disability in many instances. It becomes more difficult to function optimally. And so if we have particular policies and approaches that place persons that are aged lower in the social hierarchy, if we have practices and policies that place persons that are disabled lower in the social hierarchy, and then you add on top of that this all of these other sorts of religion and ethnicity and race and gender identity and sexuality and all of these other factors in which we have various hierarchies around, it can be very difficult to get and expect equal care and to do anything about these differences, these disparities that are preventable. So the solution here really has to be an anti-racism approach. And what that means is that in order to address all of these other things, even though racism may not be a primary concern for for maybe perhaps the majority, the reality is that it affects the majority in a variety of different ways. And one of the ways in which we have one of the ways in which we have some things that helps us to deal with anti-racism within organizations, and particularly within health organizations, are the national standards for culturally and linguistically appropriate services in health and healthcare, which were often referred to as the class standards. The U.S. Department of Health and Human Services developed these standards in around 2011 or so, and then they updated them around 2016. And these are 15 standards that were really developed to improve healthcare quality and to advance health equity. And it was done and developed in a way to give organizations frameworks to be able to serve increasingly diverse communities and really be able to distribute power within the organizations. And so some of the things that are recommended within these guidelines are, for example, doing an organizational assessment to really understand who is it that you are serving, and are the people that you are serving, so the communities that you're located in, what are you doing to make sure that the voices of the persons that are a part of that community are heard within the organization? If you are doing problem solving, if you're part of a scientific community, how are you making sure that the problems that you've determined are a problem are really that the people within the community have those same ideas or beliefs about that problem, how it's structured, and how to solve it? And then what are you doing to change some of this hierarchy? How are you engaging not just communities, but elevating individuals within the organization in order to have a more shared power approach? And so does the community that you're serving look like the organization that's there? And if not, why? Why are there significant differences there? And so I think that the class standards provide a really strong framework for evaluating, or for organizations to think about how to implement these things. And the class website has a lot of examples of organizations, particularly hospitals, that have successfully implemented the standards, and some of the strategies that they have done to do so. The other thing that I think is really helpful within this process, as we think about bias and consider differences and how they influence not only our own perspectives, but how they become embedded within organizations, is what is the process of undoing? And one of the things I think that's really helpful, one of the concepts that's really helpful in this process, is this idea of cultural humility. And essentially, cultural humility is a lifelong process of self-reflection and self-critique, where individuals not only take the time to learn about folks who are different from them, but also starts with an examination of their own beliefs and cultural identity. One of the things I think that happens often in this work is what we call othering, where we we think about problems in terms of like us versus them, but we really don't think about our own cultural identities. Our first cultural group, everybody has one, is the people who raised you. And so whoever it is, whether you were raised by parents, aunts, uncles, grandparents, whether you were raised in the US or a different country, if you were raised in a religious or a non-religious household, whether you came from a very large family or a very small family, all of those various things, those factors, influence your decision making, your values, and your beliefs, and the things that you hold to be true. And all of those things also influence your decision making. And when individuals get into positions of power, they then can become reflected within organizations. And so what cultural humility says is that it's important to recognize your own positionality. But also, I think the other part that isn't necessarily a part of this particular definition, but certainly a part of cultural humility is is understanding that there are also going to be mistakes along the way, as this is a lifelong learning process. So um, what I would like to do, I wanted to make sure that there was plenty of time for discussion here, is open it up to take your questions and your to have a conversation, right, about these ideas about how where health disparities come from, and then how they are affected or can affect health, and particularly health for the older adult.
Thank you for that presentation, Dr. Robinson-Lane. Appreciate it very much. I'll remind people what I did at the very beginning, that you can put your question in the Q&A through clicking on the icon, and then you just type in whatever question you have, and it will show up there for us to see. And at this point, a little bit unusual, and in this case, surprising, we don't have questions in the Q&A at this point. That alone raises an interesting question as to why that's the case. But let's see if some come in. And I usually, in this situation, as moderator for Osher Lifelong Learning Institute, where I'm usually a moderator, professor, I would usually, oops, here comes a question, I think. I stalled long enough to get a question. Okay. Here's there's a good leading question right off the bat here, I think. The question, the viewer asks, hypertension is an exemplar of disparities. What has been happening more recently with hypertension from your knowledge?
I think, I mean, there's a lot of things that have been happening with hypertension. I think that some of the work that my colleague Lynette Jones has been doing relates to hypertension is understanding the brain and body connection between decision making, and understanding how we make decisions, and also influencing the intergenerational role that we have amongst families, and how we think about our decision making around food and habits. I think that there's also been a push, because hypertension, heart health is very much tied to diabetes and to kidney health. I think that there's a lot more examination of some of these race-based evaluative factors in kidney function and heart function that are out there. So there's a lot more conversation about, should we really be looking, and even with anemia, right, with some of the lab values around iron, there's differences between genders. And so there's a lot more question about why. Why is it a different standard of whether or not you're anemic based upon whether you're male or a female, or why is there a different level at which it's determined that you need referral for kidney disease based upon your Black or white. And so I think those are some of the conversations and things that we're more carefully looking at policies and revisiting as what's happening generally.
Thank you for that. We now have questions coming in at a good clip here. So let me try to take a look at them. This is a general question. What is being done to alleviate these disparities?
Well, I think that there's quite a bit that's being done to alleviate the disparities. I think, like, for example, with the, for example, we talked a bit about the food deserts and how it's influencing care outcomes. One of the things that has happened is like in the Detroit area specifically, I can speak to, there's a large farmers market there, and there was an initiative so that individuals that receive food stamps or the supplemental income for food are able to use that to purchase fresh fruits and vegetables, which are often at a much lower cost. in that space. It doesn't necessarily help everybody that may have, transportation or other issues to get to that space. But there are small things. There's been more initiatives around community gardens, more engagement with local community groups that provide services to these areas. So I think a lot of grassroots initiatives are what's making a difference in communities that are experiencing large amounts of disparities. But to be clear, this all isn't necessarily, I think one of the things that we frequently see, and that happens a lot, is that often when there is a disparity and we can see that it's related to disability or race in particular, race and ethnicity in particular, I think that there's a habit to say, well, isn't it income? Isn't it socioeconomic status? And I think that there's a lot of research that's out there that demonstrates that when you control for socioeconomic status, and in some instances, like with older adults, education can be used as a proxy for that, because if you're only looking at income, a lot of older folks aren't working, so their income isn't gonna fall in the same ways that younger folks will, that we still see these disparities when you control for that. So it's not just about being low income or the presumption that individuals have are undereducated as to why these disparities exist. And I think that those frameworks still sort of shift blame to the populations experiencing the disparity rather than it being a challenge that we need to address as a community.
Thank you. A question, a little different approach. What can we do as older adults, the viewer says, to help protect us from ageism?
Well, I think that you have to push back against it. I think that when you see it, you have to say when you see it and speak up. One of the things that I love about the new generation of older adults is you guys are mighty. There's a whole lot of older adults, and they hold a whole lot of money, because there's so many older adults. And so what that means that there's a lot of power. And so I think that you can leverage that to make a difference. It means that instead of just enjoying, your retirement, that you might have to still be a bit engaged and paying attention to what's happening socially and politically, and particularly at at your own community level. And sometimes I think that there's a habit of maybe leaving that to the younger folks, and I think that there's a nice balance between being able to relax a bit and enjoy yourself and do the things that you want to do, and still staying engaged to make sure that you're advocating both for yourself and for your children that come after you, and making sure that you have the services and the things that you need, and the things that really all older adults should have, which is a high quality of life, and being able to have those various components that make that more likely.
This is a question related to COVID. Please clarify, did poor COVID results for seniors mostly happen due to disparities or the disease itself?
I think that if I'm hearing the question correctly, COVID is a very dangerous disease, but if you look at the international response to COVID and look at the COVID outcomes in other countries, the US is absolutely ridiculous, and they haven't had the level of spread in other places, the amount of infectivity or spread, nor the amounts of death. And so much of what we have seen here in the US has been a result of the COVID response here, which is still incredibly variable depending upon the state that you're in. So there has not been a consistent national response to COVID. And what has happened has been, it's been a bit late, to be quite frank. And so certainly COVID is a very dangerous disease. It's going to affect the most vulnerable, and in many instances, older adults, in particular those that require care, that are in nursing homes and with dementia, present with a larger risk. But our response is what was problematic here from the very beginning and throughout, honestly.
Could you give your viewpoint on how insurance, I think health insurance, affect health disparities?
Yes, and so with health insurance, I think that, the goal of insurance is to keep costs down and to keep people who are healthiest insured. It's sort of the way that it works. And so one of the challenges with insurance is that a lot of, so one is based upon whether or not where you work makes a difference on what sort of insurance is offered to you. And for individuals who may be disabled, for example, or below income that may have Medicaid insurance or state-sponsored insurance, then the available services, when you can get in for those services, are widely variable. So for example, if you have Medicaid insurance, it can be very challenging to find a primary care physician who takes that particular type of insurance that you have. And so we have been looking at differences, I think, within our health system here at U of M, in how insurance has played a role in care outcomes. And I think that for example, one of the primary areas that we're seeing it is that you may not be getting access to care. So if you come in through the emergency room and you don't have insurance, once you're stabilized, you probably are going to be referred to a different system that provides care for individuals who are uninsured or underinsured. And in some of those instances, it may be a large delay between when you can actually receive care once you are referred. So there's certainly a difference in how you're able to access various health systems depending upon the insurance that's available to you.
Here's another one that's related to COVID a little different way. And that is, we've heard about some rationing, that is routine care or elective surgeries, that type of thing. I think the viewer is asking about rationing of those everyday services because of COVID. But would you say that the way that is playing out, the best we can tell, that also promotes health disparities?
I think that to some degree it absolutely does. I mean, I don't know in terms of rationing the services. I know that there's been a lot of policy changes around that in particular. I mean, at the end of the day, if you have an infectious disease and you have limited staff and you have a disease or a virus that is not only affecting the people coming in, but it's also affecting the staff available to care for the folks coming in, you only have so many resources. And so I think in terms of rationing services, it always has sort of been that the most critical folks, are those who are cared for. But the problem is that we end up running into a situation where you have people that may not have been critical, but now have become critical because they couldn't get in for some of the services due to a variety of, delays due to COVID. So I know that there has been some instances where these elective surgeries some of them are very important surgeries that people need in order to be, functional, to not have pain and a variety of other things. So they're not getting cosmetic surgery. It's not elective in that sense. But certainly making a significant difference on health and outcomes for individuals. So
thank you. These are two questions from two different people, but I think they're related enough. I'll put them together. You had mentioned redlining, and you showed some maps related to that historically in Detroit. Specifically, the questioner has this question. And they're asking first, has it improved, this issue of redlining, and kind of what factors influenced the welfare of historically underserved people in Detroit because of the redlining? And then the other question, really, I think deserves to be put into this one. And they're asking whether redlining is now in the form of gentrification.
Yeah, I'm glad you asked that, because that's something that I really was sitting and thinking with as I was actually putting a lot of these slides together, is that it's really fascinating that, so the red line, and the reason I showed the red line and map from 1939 is like those people in those neighborhoods really haven't changed, right? And so it so I think that some areas have become more diverse, but like with any area, you still see the habit as an area that is highly segregated becomes more diverse, that people tend to move further away because there's still this perception that property values are going to go down simply by having more diverse folks living in the area. And also by having, and when I say diverse, it's not even necessarily just racially and ethnically diverse, but also income diverse. There's lots of pushback against putting into place, like, for example, housing or shelters for homeless individuals within communities because of biases, often unfounded, that individuals have against people who are simply different from folks that are like them. And so gentrification is really interesting because what happens is people that have historically avoided neighborhoods because they were redlined or noted as hazardous, move back into or move into these spaces, and then it sort of begins to shift this idea. And so does it make sense? I mean, like, I think the problem with gentrification is that if individuals were moving back into these areas, meaning that we have more white folks moving into areas that have been historically individuals from minoritized backgrounds live there, and we're becoming a part of the community to sort of leverage things, I think that will make a difference. But that's not what's happening. What's happening when gentrification is that you have high income individuals that are moving in, and basically the residents who have been there and maintaining and supporting the area are being pushed out. And that has happened in Detroit, in a lot of areas. For example, we had some large units where older adults have been living, that have basically been pushed to a completely different side of the city that's further away from local services and supports in that area. So that's one of the large challenges and problems with things like gentrification.
Thanks. Got a series of questions here that I won't indicate the category, but I think you'll see. I think I'll ask them one at a time because I think they're different enough, but they're sort of related. This viewer says, is there an acknowledged or suggested model for engaging in self-reflection about these disparities?
I don't know that there's necessarily a model. What I recommend, and what I often do, which I didn't at the start of this presentation, is often these sort of conversations are really uncomfortable for a lot of folks, because it really makes you sit and think about, like, okay, this is making me uncomfortable, and like, why? And I think that's the process, is to really sit and think about, like, what's your positionality? What are the beliefs that you hold to be true? So what are your values? What are the things that are most important to you? And then thinking about what are the ways in which you use whatever position and place and power that you have to make a difference in these spaces. And so for me, what that looks like is I'm very thoughtful, for example, about mentorship, because I know that that's made a significant difference on my journey. And so I'm very thoughtful about making sure that, like, I'm mentoring others. Or if I'm doing a project that has anything to do with the community, I'm very thoughtful about getting community leaders and organizations engaged with that project to get their perspective and make sure that I'm including their ideas, and also thinking about how are we also compensating them? Are we just gathering their information, using their space, but then all of the power and money comes outside of these groups? So those are the sorts of ways that I'm very thoughtful about, changing the sort of hierarchical narrative. and the power distribution, and thinking about my own positionality. So I don't think there's a model. I think it's just more so an active process.
This one, a little different approach, but I think has similarities. Are there strategies that you find useful for helping people engage in cultural humility in an authentic way?
I think that part of it has to do with the organizational culture of one, being very thoughtful about emotional intelligence and being clear about like where you are emotionally and what you're bringing to the conversation, having a safe space in order to be able to talk about and discuss things, and thinking about why do you want to have a workplace or a organizational space in which these things, these concepts really make sense. And so if it is a safe space, if you are, and as an organization looking at improving those, I think that you have to have like some sorts of agreements, or I hate to use the word rules, but more so like agreements about how to interact and engage, so that there's a space to be able to talk about these challenges, and to actually challenge, is some work being done, or is it what we call performative? So do we just want to look like we're making a difference, or are we actually willing to put the work in to make a difference and to create an inclusive space? And one of the things I hear sometimes is like, well, we don't have diverse people in my work setting. Well, the question should be, well, why? And how do you know that? Is it that you have created a space where people who do have some differences, whether it might be invisible disability, or perhaps they are part of a family that's very diverse, do they feel comfortable in speaking their truths and being open about being their authentic selves within the space that you are creating? And that's where that idea about intersectionality comes in, is organizations, and particularly leaders in organizations, have to be really thoughtful about whether or not they are creating inclusive spaces for the most marginalized folks among them. And then what does that then look like? And then when someone does bring up a challenge or a concern, how is that then addressed and managed in a way that not only addresses the problem, but also lifts up the individual that was bold enough to bring forward that concern?
Thank you for those thoughts. This one is a little different angle in the health system. How well are medical schools addressing these macro, micro biases in healthcare? I assume they mean in the training of physicians.
I think that that is quite variable about how it comes up. I think that there's still certainly a lot of work to be done, as evidenced by just the experiences of physicians themselves that come from all of these different diverse backgrounds. Um, so I think that there's still quite a bit of work that needs to be done to that end. And I think that there has to be more training embedded within programs that gets people to think about these contextual factors that contribute to health, because I think that that would also influence some of the recommendations, that you might get. For example, it might be a part of a standard assessment, to begin to ask about social determinants of health, because we recognize that that's a problem. But if you're asking somebody whether or not transportation or housing is an issue for them, my question is, why are you asking questions that you aren't prepared to do anything about? So now you've asked someone about whether or not they have a challenge with housing. Are you familiar with, or is there a process for referrals, so that if someone does mention that they have an issue that is creating a challenge to them meeting their optimal health needs, that we're able to actually deal with that? Or are we just collecting the information because it's another box we have to check? And so those are the sorts of things I think that we have to be thoughtful about, both within training, so people understand that all of those steps have to be carried through, but also in implementation.
Thank you. Could you expand on your statement of how addressing racism is foundational and will have an impact on other kinds of discrimination?
Absolutely. So part of the reason that I framed much of this conversation around racism is that that is where I think some of the longest history within our medical system here in the U.S. is around has been centered around racism. You know, it wasn't until the passage of the Civil Rights Act in 1965 that all individuals even had equal access to medical care here in the U.S. So that means for every single older adult that's over the age of 65, anybody that's not white did not get equal medical care their first decade of life. So you already are in a disparate system, and most people don't like recognize that. And that's something that was embedded into the way that care was delivered as a matter of practice and policy here in the United States. And so by looking at something that was had very clear laws and regulations that then became, you know, embedded into all of these levels that we had spoken about, I think it creates a space that can benchmark the process for dealing with all of the other isms that we might see out there. And it moves to this space of creating more equitable spaces for everybody. And we've seen that, you know, when we address, we've seen that in a variety of different spaces where when there's a more consistent or persistent anti-racism approach, it creates a much better environment for individuals of all sorts of disenfranchised backgrounds and underserved backgrounds.
Okay, thank you for that. A little more specific type of question on disparities. What is the difference in maternal health outcomes between Black and white mothers in Michigan?
I'm sorry, can you repeat that?
Sure. What is the difference in maternal health outcomes between Black and white mothers in Michigan?
In Michigan, I'm not for certain about what the specific Michigan data is, but generally speaking, I mean, like, you know, there's a much larger mortality rate between Black and white mothers where Black mothers have about 3 times more likely to die in childbirth you know, as compared to white mothers. There's also differences in care outcomes, you know, whether it's the preeclampsia and all sorts of other maternal health related outcomes that are challenging and make a difference in care. I mean, like we can go on and on about the various different sorts of disparities, like, but essentially in almost every single health area, there is a preventable difference that is likely and can and has been tied to race, ethnicity, gender, and all of those various things. And so I think the key is though, and what I'm sort of stressing is getting folks to think more about what is causing those other than just like being Black or being white or having a particular income. What are some of the factors? And then what are the things that we're able to do from a systems perspective or even at an individual level to make a difference there? And part of it is just being aware.
Thank you. Here's a more specific question also. I would say this viewer says, I'm a retired hospice registered nurse. Can you comment on racial disparities in minority access to or acceptance of end-of-life care?
Yeah, I think this has been, I mean, been in long-term hospice nurse as well. And I think part of the conversation around hospice care that makes it challenging when you talk about racial and ethnic differences is, as I mentioned, there has been a long history of receiving unequal care for individuals of minoritized background in the health system. So if you have a group of individuals that are used to not receiving optimal care, and now when they're at their very sickest, you're telling them that they have the option of not doing anything, it makes it's challenging. And so there's a lot of folks that are going to push back against that and say, nope, you do everything possible until the very end. And then there's also, that's part of it. And then also you have a different sort of religious focus for a lot of individuals, in which there's a different cultural view of end of life care and a view of the role of organizations and facilities, where the belief is that God is the healer, God has the final word. And so in that engaging in hospice care sort of goes against some of those like cultural ideas. So the point is that this is very layered. It's not necessarily as simple as access. I think that in the instance of hospice, that people have similar access. I think that the challenge is reevaluating perhaps how hospice and palliative care is delivered. Are you meeting with individuals to understand what their needs are, and then developing programs that are more culturally responsive to the needs of that community? So it may be that we don't need to increase access to hospice, but maybe hospice needs to think about its care delivery in a way that meets the needs of communities that may not be comfortable with the current way that hospice is delivered. Maybe they're more suitable for a palliative care program rather than a hospice program.
Thank you. Here are two questions that really relate to patients encountering issues related to disparities in treatment themselves. So let me ask the first one here. If you feel you're facing negative bias when seeking healthcare, do you have advice on how to productively advocate for yourself?
Yeah, so I think that one, it depends upon where you are receiving, where you feel like the bias is. So one of the things that I suggest, number one, please keep notes. So keep yourself a healthcare notebook or some other means of documenting the care that you're receiving, so that when something occurs, and a lot of times our response is not to say anything because you need to meditate on it and think about it. So write it down when you get home into your notebook about what the date was, who the provider was, or what the instance was in which you are not feeling comfortable or you felt as though there was some bias there. And then circle back. If you are feeling confident in the moment, I always question and say, well, can you tell me why you suggested that? Or what do you mean by that? If somebody makes a statement that is maybe inappropriate, or it seems like it's something biased, or if you know it's just not true, like say it's not the protocol, it's okay to say, well, my understanding is that A, B, and C should have happened. Can you tell me why you're suggesting this, which is different from what I would have expected? So I think that it's okay to be affirmative and to speak up in a way that isn't what people may consider to be confrontational, but questioning, right? And then I think that in some instances it is okay to push back largely, so that if there are specific ways in which you feel as though there's bias, I always think that it's important to put it into writing. So whether that might be sending an email or actually writing a letter rather than making a phone call, organizations often, by having that written record, are more likely to have to follow up and provide some responsiveness related to that. And the thing that I've found frequently is that your complaint isn't the only one. And so it's important to speak up when there are instances of things that are occurring, because sometimes it might be that if it's like related to a particular provider or a particular setting, these are opportunities for improvement for within those spaces. And if nobody ever says anything, then they'll continue along with the status quo, or make excuses as to why why it happened, which often goes to blame shifting with the individual.
This other related question I think is a little bit different. You covered it partially maybe, but I think this one is a little bit more from this viewer. How do you get providers just to pay more attention to their healthcare concerns? And also any particular questions or behaviors that you recommend to get that message across to the provider of healthcare that they're encountering?
Well, I don't think people realize how like nerve-wracking it could be to go to an appointment because you have all of this stuff that maybe you want to talk about. And then if you have a provider that's talkative and they come in and you start talking about something, we forget and we don't always bring up our concerns. And so I think that there's sometimes maybe a presumption about how much the provider is able to figure out by just looking at you without necessarily you speaking up about whatever your concern is. So one of the first things that I recommend is get yourself a little note card, or nowadays everybody has phones. So there's probably like a notes app or something on your phone that you can put in a few bullet points of the main things you want to speak with your provider about. Um, and so that helps to make sure that you get to address everything when you go to your appointment. And so, and I like the paper because then you can bring your paper and say, I got a list of stuff I want to talk to you about. I don't want to forget. And then they may even remind you, if you bring your paper and still forget, about some of the concerns that you're having that may not be addressed. If it's an issue where you don't actually have an appointment and you're trying to get in and you feel as though you're not being heard, one of the things that's also effective if you have not been able to connect with like your healthcare provider is to actually call and speak with the nurse. Most practices have a medical assistant or a nurse that is working with the practice that may be more likely to return your call, where you can speak directly with them. And then they may be able to advocate also on your behalf or provide some additional information. If maybe that's not the right space for you and you really should be like receiving care someplace else, or can give you feedback that might be helpful to you. So, but the main thing is to write it down to make sure you get everything covered.
Thanks for that. Oh, and actually, one more question related, I think, somewhat to the same two we just talked about, and that is more generally, is there something that older persons, elderly people, can do in the community as activists, I think they're indicating, to really try to go beyond the individual encounters you have with the health system and try to affect larger change in some way?
Well, I honestly think that there's lots of different ways to get involved with community groups. That's one of the great things about the current time that we're in, is that there's so many different community initiatives that are taking place to make a difference within the community. It could be, believe it or not, something as simple as the reading program. Most of the elementary schools, I mean, now things are a bit different with COVID, but most of them need, and they have had a need for like people to come in and like read. So, for years when my oldest was younger, and I'll probably do it again when my little one is in kindergarten, was going in and reading to the kids at the school or after school tutoring programs or health navigators. So there's lots of different volunteer roles that can help to bring advocacy and information to individuals. And I think particularly for individuals that have training or expertise in particular areas that may be retired, there's a lot of folks that can use your skill and expertise, even if it's like within a community organization. Places like Meals on Wheels or your local senior center really need individuals that have a few hours a week to give to help these organizations to do better at their role in serving the community. So it's not something that you certainly have to do on your own. I think that's the best way, is to look into other organizations that are near you, causes that are maybe near to your heart, and to find ways in which you can volunteer.
Yep. Well, it's a very large effort for sure. A lot of work to be done there, I'm sure. Another question really relates a bit to your model about determinants of healthcare disparities. And I think it's worth asking simply because it reinforces a little bit of what's in that model. And this person indicates that poverty, I mean, fundamental poverty across the country and beyond, I suppose, seems to be, in their view, at the heart of a lot of these disparities. So do you want to take on that somewhat broader question related to some things you said in your talk?
Sure. And so poverty certainly plays a role in disparities, but as I've mentioned, when we control for income and when we control for socioeconomic status, we still see these disparities. And so while poverty might be a factor in some instances, it doesn't explain these disparities in all instances. And that's because when there are structural biases in place that prevent equal access, equal engagement, um, um, taking individuals seriously regarding their health concerns, um, referrals, all of these different things. It doesn't matter how much money you have or necessarily even where you live if biases are going to prevent you from being able to get the care and the support that you need. And like I said, there's been a lot of research in this space. That's actually for those of us that do a lot of work in health disparities and publish papers. That's honestly the large feedback that we often get, and so it tends to be standard for most of us to address socioeconomic status in our work to be able to clearly demonstrate that, like, yes, socioeconomic status was factored in, but these problems continue to exist outside of just, finance. It's not just about wealth. But with that said, one of the challenges and one of the paradigm shifts that will have to take place is within organizations, the focus often is on finance. I mean, like, that's the primary rationale that was used for slavery, right? Is there's nothing like free labor. It doesn't get any cheaper than free labor to cut down on costs. And so for organizations, it means that we have to shift in paradigm and think about how do we provide the most moral and ethical care and still be able to do the business that we would like to do.
Thank you. Second here. Okay, sorry. Kind of juggling things here as we come near the end here. We got a few more minutes. Yeah. This is a very large question, but it certainly relates to what you tried to address. What one structural change in the four types of layers there that you talked about at the very beginning in your slide, what structural change would you think would have the greatest impact on racial disparities among the many structural issues?
I think it has to happen at the systems level. So, we got to look at institutional racism, because that's what is influencing the structure. The structural racism is built upon what's happening within organizations. If the organizations have stronger, it's not just about policies and procedures. I'm going to say stronger approaches at leveling and recognizing the ways in which they may be upholding isms, not just racism, but isms in general within their organizations. And that's when we will start to see change. So if you're in an organization and you've got all of the boards of directors on all of the walls, and everybody on there is a white male, I think it's important to ask, like, why is that the case? And what are the things and is this reflective of the work that we want to do? And then maybe in some instances the answer is yes, maybe, I don't know. But it has got to start, there.
Have to start climbing the mountain somewhere. Yeah. Well, that's a good analogy or not. Here are just two last questions as we get towards 12:30 here and our limit for Q&A. Can you think of any positive exemplars of organizations who are doing well with health disparities, trying to address them?
I feel like the public health departments are doing a fantastic job of trying to and doing well at addressing health disparities. I think that for example, in the COVID response and making, like, for example, where testing and stuff was done, going out and reaching out to community partners, engaging churches, community centers, having community forums, inviting leaders. people with opposing views to come and be able to talk in community forums about what was taking place. I think that this good work of creating spaces where people have equal voices is happening at the community level, and that it needs to be more reflective within larger organizations, and particularly large organizations with health systems.
Oh, here is a last question. Last but not least, I don't think you addressed this a little bit in your talk, and it's out there everywhere these days. How do we respond to the persistence of bias based upon bad science and unwillingness of white folks to accept the reality of racism as a factor in our nation?
I think that you just have to continue to present it with facts. I think that whenever you have to be thoughtful about the audience that you are addressing, for sure. But I think that you continue to address it head on with facts, by demonstrating, if the argument is always going to be that race isn't the problem, that it really is socioeconomic status, or it really has more to do about education and those sorts of factors, and it's important to include those factors when you're talking about or writing about publishing and teaching about these things in order to demonstrate the truth. And I think the other thing that has been most fascinating to me is that a lot of the knowledge, historical knowledge, that we may take for granted is not stuff that's necessarily common knowledge. So even though I think people intuitively know that the civil rights movement changed stuff, I don't think people really operationalize that and recognize that that means that you have a large segment of the population that wasn't receiving equal care. So I think that we just have to continue to put the message out there, continue to put facts out there.
Appreciate that. Well, I want to thank you very much for bringing to the presentation your knowledge and experience and research you've done. I've had many comments in the Q&A and the chat indicating already a very high praise for your presentation and your responses to the questions. So I want to convey that to you and let you know I certainly agree with that completely. And I would remind people before we totally get off here that I mentioned that the presentations in this series will be sent out to the registrants who registered for the series in due time. Apparently, they're going to be put onto YouTube. And so that information, though, as to how to access those will be made available. And also, I mentioned at the beginning, there are 3 more in this series. The next one is a week from today in the afternoon from 2 to 3:30. It is on LGBT older adults, closing the gap on health disparities for that part of our population. So again, though, Dr. Robinson-Lane, thank you so much for giving of your time and your expertise. It's really been a pleasure to view your presentation and deal with you in the question and answer section. And I hope you continue, and I'm sure you will, to do your good work and stay safe and healthy in the meantime.
Thank you, and thanks again for having me.
Sure enough. Take care. Bye-bye.